So we're good to go. Good evening, everyone. This is Antoine Nico from Medimaps. Medimaps is the creator of a Tbs software which provides a trabecular bone score. Tonight's webinar is a presentation of the integration of this Tbs into osteoporosis management. What does Tbs evaluate? What clinical benefit does it offer? And how our two speakers of the day use it in their centers, both in Saudi Arabia and Lebanon. For this webinar, I have the pleasure and also honor to introduce you to Dr. Kamel Mroué. He is president of the Lebanese Society of Rheumatology, also head of a rheumatology division at Al-Sahra Hospital University Medical Center in Beirut. And Dr. Mohamed Al-Mohaya, consultant of endocrinology and metabolic bone disorders at Obsity Endocrine and Metabolism Center in King Fahad Medical City. He's a director of adult endocrinology training program also in King Fahad Medical City, board member at Saudi Osteoporosis Society, and is a specialist in assessment and management of osteoporosis and metabolic bone disorders. This session will start with a presentation of first Dr. Kamel Mroué. We will then go in a second time with another presentation from Dr. Mohamed Al-Mohaya. And at the end, we will keep a session of 15-20 minutes of Q&A. Please write your message or questions in the Q&A section, and I will make the question to our two speakers at the end. This session is recorded, and for people who want to review after this video or didn't have the opportunity, we'll be able to send it to visualize the video in a second time. So Dr. Mroué, you have the possibility, I believe, to share your screen. If not, I will give you the access.
Thank you, Antoine, for your introduction. Are you hearing me?
We do, yes.
Yeah, I'll start. I'm Dr. Kamel Mroué from Lebanon. I'll talk about the trabecular bone score in osteoporosis. My agenda is to give a brief introduction on osteoporosis. Then I'll talk about why do we need to have the FRAX, and why do we need to have what's called the TBS. Then talk something about the technical fundamentals of the TBS, and then what's the added benefit in our clinical practice from this TBS, and then we'll end up with some sample clinical cases. WHO have defined osteoporosis to be as a silent systemic skeletal disease characterized by low bone mass and a microarchitectural deterioration of bone tissue, leading to an increase of bone fragility and an unacceptable risk of fracture. So with osteoporosis, we have mainly two things. We have low bone mass, I mean, we don't have enough bone, and on top of that, we have a bad bone, okay? We have two important things, and this will lead together to easily breaking bone, and this will lead to an increased unacceptably risk of fractures. How do we measure osteoporosis? How do we use to measure osteoporosis actually? We use the Dexa scan machine, which is an abbreviation for the dual energy X-ray absorptiometry, which sends two X-ray beams with different energy levels. These are aimed at the patient's bones. And because these beams have two different energies, they will penetrate our body differently. I assume that the the weaker energy level beam will only penetrate up to the soft tissues, and the stronger one will penetrate down to the bone. And if we subtract these two energy levels, or the absorption from these two energy levels, we get what have been absorbed by our bone. And this will be translated into how much bone do we have in our body. By this way, we can easily measure how much bone do we have. And because these machines work in 2D, two-dimensional way, we speak about areal density of bone. You know, density is always in our high school or school, it's the mass of something divided by the volume. But in this context, we have the mass of something divided by the area of that matter. Okay, this is why we speak about areal density, not volumic density here. And because of high-tech computers, these machines or these softwares can manage translating the areal density into a volumic density in the end. This Dexa report, as we all know, we'll have this Dexa reports. We measure the density at the hips, at the forearm, and at the spine. We get these bone densities at these areas, and this will be translated into what we call the T-score for standardization, because you know we have many machines on the market, and for standardization issues, they created this T-score concept. So if we put any density, for instance, at the hip or the spine or the radius in a certain machine or in different machines, you will get the same, practically the same T-score. And out of these, we have the new modality of FRAX, which is a software that gives us the risk in 10 years if we will fracture or not, whether at different areas, major osteoporotic fractures, or at the hip. Okay, where we put in this software the density at the hip neck, and we put inside this software the different risk factors that the patient have, and the software will calculate this risk, and we'll have numbers. Out of these numbers, we will treat the patient or not. And this treatment threshold is different between countries, okay? Depending on their economic status, depending on the risk of hip fractures in that country. But as you well know, bone fragility is not only translated by bone density or how much bone we have. It has we have other factors that are related to this issue. We have bone geometry and macro architecture. We have the micro architecture. We have the mineral content of the bone, and then we have the bone turnover, which is the net change in bone formation and bone destruction. As you well know, the bone geometry is something most probably related to congenital issues, and other parts of display are the bone turnover and mineral content. They are in one way or another, I think, they are related to the bone density and bone microarchitecture, or the bone mass or bone quality. So if we have a means to measure the bone mass and the bone microarchitecture, this will be fine for us. Why I'm saying so? Because many of our patients in our real life practice, they still fracture at normal bone densities or even osteopenic bone densities. I forgot to mention that the T-score that we got from our Dexa machines will tell us if a patient is osteoporotic, if the T-score is less than minus 2.5 at any of the 3 sites that we talked about. If the T-score is between minus 2.5 and minus 1, the patient is osteopenic. If it's more than -1 or above -1, the patient has normal bone density. So if we have a patient with normal or even osteopenic bone density, these patients can still fracture. Okay, how much is this percentage? It's around 50%. So half of our osteoporotic fractures are still not in the osteoporotic range as far as the bone density. So we conclude that we have other factors playing in the ground of osteoporosis, not only the bone mass. As we have said, we have other factors, mainly the bone quality. Okay, what's bone quality or bone microarchitecture? You know, bone is like sponge. We have areas of bone matter and areas of space, emptiness. Okay, this is for healthy bone. And these, if it's osteoporotic, we'll have more spaces and less bone, thus less trabeculae, less length of these trabeculae, less trabecular number, less trabecular thickness, and more spaces. Can you measure this bone microarchitecture? Yes, it took a lot of time, a lot of energy, a lot of investments to create this trabecular bone structure. It was not possible without complex procedures, expensive technology, and even extra radiation to the patient. Okay, in the end, they created gratefully for these companies trabecular bone score. Actually, the first publication on this topic was 12 years ago, when they created this software, and they mentioned that it was an add, a complement to the Dexa scans. What's this TBS software? It's an advanced imaging software that complements the Dexa scan. They take the Dexa scan of the lumbar spine, they translate it to a TBS score, and we have different numbers. If this number is more than 1.31, then we have a high TBS score, meaning that the bone is of good quality. If it's less than 1.23, then this bone is degraded and of bad quality. In between, it's partially degraded or partially bad bone. Okay, this advanced imaging software can be translated easily on what we think digital world has been these days. You know, these days our world is digital, and we talk about pixels. Pixels are the smallest units of photos that these cameras can take. Okay, imagine these smallest units of photos that the digital camera can take. Then they will take small squares of different colors, different brightness. We'll have the white, the gray, or the black colors, and these different coloring pixels or cells will be used in the TBS technology. In the Dexa machines that we all know, these small squares of bone, okay, 2D photos are translated into pixels, like as we are seeing, like the chessboard, okay, with different brightening squares. Okay, the gray squares are bone, I think. The white are, I think they are nothing, and the black are air or vacuum. Okay, if in a certain area, if you count these gray squares, then you are able to calculate or to measure how much bone do you have in this square. So you can translate this into a bone density of that bone. Okay, so simply the Dexa machine just takes the sum of these gray squares, and this will be translated into an aerial bone density. Whereas the TBS is slightly different because in the TBS we are looking at the difference in brightness between these smallest areas within these squares of bone. Okay, the more you have differences, meaning that the more you have bone, the less you have differences, less you have bone and more empty spaces. Look at these two squares, they are translated differently. Here we have more heterogeneous differences in brightness of these small squares. Here we have less heterogeneity. And if we calculate the difference between one cell or one small square with the next adjacent to it, the more we have differences, then the more we have bone. Okay, the less we have differences, the less we have bone, I think, or bone. If we have, I mean, more heterogeneous bone, we'll get a higher TBS. We have less heterogeneous bone squares, we have lower TBS and less bone quality of bone. Okay, so this TBS calculation comes from the difference in these difference in the brightness of these cells. Calculating the sum of the squares of these brightness differences will give us the idea on the how much bone in this, how much bone is scattered evenly in this square of bone. Okay. To make the idea simpler, we may have two DEXA scans of two lumbar spines that have the same bone density. So in this square or rectangle, I mean, we have the same amount of bone up and down, but these bone in one in the upper rectangle are dispersed evenly. In the lower rectangle, we have more spaces, empty spaces, and these bones, amount of bone, are spaced unevenly. This will be translated to a better bone quality in the upper one and less bone quality in the lower one, leading to a higher TBS up and lower TBS low. So we may have the same amount of bone in two different areas, okay, but the bone is scattered differently in this area, leading to different quality of bone. And this TBS score was actually very well validated, okay, with the microarchitectural parameters that we all know, like the trabecular bone number, trabecular spacing, trabecular volume, and what they call the structure mode index. These was very well correlated with these parameters, and they did well. Okay, so also the TBS score very well validated and found to be independent with the bone density and the other clinical risk factors. For instance, as you well know, patient having osteoporosis will have higher risk of fracture than the patient having normal bone density. Also, patient having normal bone, if a patient normal bone density, if this patient has bad bone quality, this patient will have higher risk factor, higher risk to fracture. Even if the patient has normal bone density, also the patient has osteoporosis, very bad bone density, this will also have increasing risk of fracture on top of the original risk that's being created by the bone density, if the patient has a bone quality that's bad. So with this, as you have said just before, patients who have same bone densities, they have different bone qualities, leading to different TBS scores, and this will lead to different, probably different therapy decisions on part of the clinician. Is this TBS has some limitations? Yes. Studies have shown that the abdominal thickness of the patient causes some heterogeneity that influences the DEXA scan analysis. But the software has algorithms for adjusting for the abdominal thickness. But we should always be cautious for patients who have higher weight, more than 85 kilograms. Okay, and an increase in abdominal thickness is associated with decreased TBS, falsely decreased TBS. Do we have technical advantages with TBS? Yes. As you well know, we have problem with the degenerative changes on the lumbar spine when we are taking bone density there. Data have shown that TBS is much less affected by these changes as compared to the bone density. This is the issue because of the osteophytes that's being there that cause a common artifact in older patients and those with osteoarthritis. These, as you well know, can further elevate the bone density, leading to the falsely high bone density at the level of lumbar spine. Okay, but this is not the issue with trabecular bone, probably because of the pathology or the exact findings within the osteophytes. Probably the osteophytes are much less spongy than, or much less trabecular bone than the actual trabecular bone that's being found in the lumbar spine. This will lead to less TBS changes on part of these osteophytes, leading to giving us the actual trabecular bone quality on part of the lumbar spine. And this is being shown by different studies. I've just highlighted these three small studies recently, 2018, 2014, and 2018, showing that the lumbar spine age-related degenerative changes are influenced much less while using the TBS as compared to that with the BMD. The TBS, as you well know, has been very well validated with many countries all over the world, and even in many international societies like IOF and the ISCD and the SQ. Okay, this gives us confidence to use it in our national guidelines. In Lebanon, actually, we use the Dexa scan and the FRAX score, and we use some machines that you well know that have TBS embedded in it, like the GE Lunar and the Hologic. We can adjust for the TBS in our final result for the FRAX. Okay, and we have the adjusted FRAX score. In Lebanon, for treatment, we use the hybrid scale for the treatment. We treat patients up to 70 years. They have more than FRAX 10% for the major osteoporotic fractures, and up from 70 to 90 years, we use a sliding scale from 10 to 30% FRAX to treat. Okay. Clinically, does it add the TBS anything on part of the fracture risk prediction? Yes. Actually, as you well know, around 40% of our patients are of the osteopenic patients have actually a moderate to low major osteoporotic fracture on part of the FRAX. Okay, around 54% have the high risk osteoporotic patients. In the osteopenic range, okay, if we add the TBS, we'll pick up more patients. Actually, 30% of the osteopenic patients will be reclassified to have a higher risk for fractures. This is the advent of the TBS. Okay, actually, the total number of major osteoporotic fractures increased from 54% to 70% with the addition of the TBS. So we have reclassified 30% of the osteopenic patients to be also at high risk for fractures. Does it economically feasible? In our countries, I doubt we have data, at least in Lebanon, we don't have exact data on this issue. But in the US, you well know that osteoporosis causes 2 million broken bones a year, 19 billion annually, and it's being forecasted to rise billion by 2025. If earlier treatment reduces the fracture rate by 50%, then we use with this simple software, the TBS, the overall risk fracture could potentially be reduced by 8%, additional 8%, saving approximately 1.5 billion annually. So in one country, you are saving $1.5 billion, okay, from a simple, not a simple, an important actually software in helping the patients to go through a process. So as key outcomes from this talk, the clinical outcomes is that we are able to identify more patients at risk for fracture, and we'll fine-tune our therapies, okay, and thus improving our patient management. On the operational stage, it's an easy to install in the Dexa machine and to use with no additional exam time, same time, and no additional radiation for the patient. This is very important for the patient. Financially, you are having a lot of savings on part of the healthcare costs in your country and insurance groups. And for clinics and polyclinics and hospitals, you are getting more patients referred for this TBS issue in your Dexa practice. So you are improving your Dexa practice if you are doing it yourself. So what patients will benefit clinically out of this TBS? The osteopenic patients, as we have said, because combining the TBS will be DBMD, will result in an increase in more than 30% of patients that are classified as osteopenic, as it's the independent predictor of risk fractures. Okay, so you are getting more of the osteopenic fractures to have higher risk to fracture. Also, patients who have a frax that's close to the intervention threshold, the use of the frax will either push this threshold, your result above your threshold, or it may also push it down. This will change your management strategy for the patient. Another benefit is, as we have said, with the osteoarthritic patients of the lumbar spine, okay, this will delineate decrease the importance of the falls the high bone density on part of the lumbar spine. The final benefit is with the secondary osteoporosis like diabetics, glucocorticoid steroid induced osteoporosis, hyperparathyroidism, oncology. There's a place for the TBS in the management of such patients, and my friend Dr. Muhammad will talk, I think, about this issue. I will go briefly about my clinical cases. This is a 54-year-old patient, okay, who have done a hologic Dexa scan. Her was -2.2. Her hip neck T-score was -2.4, and her frax was 10% for the major osteoporotic fracture and 1.9 for the hip fracture. Her TB score was good, okay. It's 1.36. That's relatively good. So her fracs didn't change much. Okay, it was 10%. It's now 9.4%. So if you have a good TBS score, your fracs origin will not change your management as far as the treatment of your patient. Another case is that this is a 76-year-old female who have a T-score for the lumbar spine that's normal, probably from her osteoarthritis. This is falsely normal, okay? And her hip neck was minus 0.9, and the total hip density T-score minus 0.6, and her fracs was 8.3 for the major osteoporotic fracture. Since she has a bad bone quality, her TBS was 1.059. Okay, her fracs, corrected fracs for the TBS dropped down to 12%. Okay, by this way, probably her physician will change the management plan for this patient. If you go to the GE lunar patients, this is a 63-year-old lady who had a bad, actually, minus 3.1 lumbar spine T-score, and her hip was around minus 1.7 at the neck, okay? And so her fracs was 6.5% only for the major osteoporotic fracture. Since she has a good bone, trabecular bone score, that was 1.4, her corrected fracs for the TBS didn't change much. It changed only from 6.5 to 6.7%. So if you have a good TBS, your fracs may not change appreciably. Another case, here we have a 52-year-old lady who had a T-score for the lumbar spine. It's around minus 0.5, and her hip neck T-score was 0.2. Now this patient had a fracs of only 4% for the major osteoporotic fracture risk. Since her TBS was very low, it was around 1, her fracs raised from 4 up to 8.3%. So if you have, even if you have a good bone density and you have a bad TBS, your fracs will increase sharply. Okay, thank you. This is Beirut after our port explosion. Thank you for listening. I'm done.
Thank you very much, Dr. Mboué. Thank you very much for this presentation. We already have some questions which will be answered at the end of the presentation. I will now hand the talk to Dr. Mohamed Al-Mohayyam. If you're ready, may you please start.
Thank you.
Have your screen ready and shared. We do not hear you, doctor. You have your microphone on mute.
Hello, can you hear me now?
Yes, now it's good. Thank you.
So, hello everyone. Thanks for attending. Thanks for Midmap's group for inviting me to present. Thanks also to Dr. Kamel for his nice and excellent presentation in regard of introduction to the TBS. I'll be talking today about the role of TBS in secondary osteoporosis and also the treatment monitoring. So, in regard of what is the clinical utility of trabecular bone score in cases where we have secondary osteoporosis, There are some certain conditions where we have the fracture risk that it's out of the proportion to the BMD, where we have higher BMD values, but still those patients at higher risk for fracture. So TBS has been shown to be an additive tool that will help us to predict what's the risk for fracture. Like in conditions with type 1, type 2 diabetes, those also who's taking glucocorticoids, either iatrogenic or also the Cushing syndrome. In cases like primary hyperparathyroidism, where we have an effect dramatically on the TBS and also increasing in the fracture risk prediction. Also in cases like rheumatoid arthritis, adrenal incidentaloma, cases where we have a CKD, mainly stage 3, 4, where we have very low TBS that might not be appreciated by the BMD alone. So my talk today will be focused on the diabetes, mainly type 2 diabetes, as we are seeing a lot of patients with type 2 diabetes. So what is the relation between the TBS and also the type 2 diabetes? My talk regarding of diabetes will be a touch based on the association between the type 2 diabetes and the trabecular bone score. Does it reflect into fracture risk in type 2 diabetes patients? Also, we'll be talking about if there is any effect of the glycemic control on the trabecular bone score, and also what is the effect of duration of diabetes on the TBS value. So I will start with this case scenario that we have seen in osteoporosis clinic in our center. She's a 67 years old postmenopausal female who comes to the clinic. She's known case of type 2 diabetes for the last around 10 years. She is on a metformin of 1,000 milligram twice a day. She is also on sitagliptin of 100 milligram, and also recently added empagliflozin of 10 milligram once a day. She has well-controlled hypertension on amlodipine, and she has also bilateral knee osteoarthritis. She reported no prior personal or also family history of fractures. She's maintaining a good amount of calcium and also vitamin D supplementation. She has no previous exposure to the glucocorticoids or other medications that might interfere or cause further bone loss. Based on the initial blood test that she had, it was remarkable initially to rule out the secondary causes, except for hemoglobin A1C of around 8.8 on average for the last 1 year. So it was not well controlled in regard of her diabetes. This is, so based on the criteria, we'll proceed with a routine BMD screening if she's above 65, but also she has diabetes, so probably above age of 50, we'll consider BMD screening. As you can see here in the left-hand panel, the image of the Dexa scan that we have, it's not the optimal study to interpret, but as you can see here in the figure, not optimal position, but you can appreciate the degenerative changes that we have seen that might reflect or causing falsely higher reading in regard of the BMD values. As you can see here, the T-score of minus 2.3, that might be not true, so falsely elevated in such condition with the degenerative changes. In regard of her TBS that has been obtained in our institute, as you can see here in the right hand panel, the TBS that will be provided, you will have the TBS values that if it's very nice, homogeneous, will have high TBS score, as Dr. Kamel mentioned. If you have heterogeneous the image and also fill of gaps, you will have very low TBS score, which is here around 1.080, which is indicating this patient has a degraded structure that assessed by the TBS. Of course, facts that we can included in the TBS report and some additional results that might be helpful. That's the old version of the TBS. We have also, I think we have an updated TBS value where we have more information in regard of the TBS measurements. So that's regard of her TBS. She's having T-score of minus 2.3. femur neck BMD T-score was minus 2.5 and the total hip T-score of minus 2.6. She has very low TBS value, as we mentioned. Certainly, if you will go by the guidelines, you will treat this patient based on her hip hip T-score that under minus 2.5. Obviously, if you go by FRAX and FRAX criteria to predict what is her probability of having fracture in the next 10 years, as you can appreciate, if you do not do the adjustment, her major osteoporotic fractures in the moderate range around 13, and her risk for hip is only 2.8. That's not exceeding the threshold for treatment in our country, which is 3%. So that BMD might underestimate her risk for fracture if you go by the BMD alone. One of the adjustments that we can do for this patient with those poor control type 2 diabetes has been studied by Leslie and his colleague 2 years back. They address certain modules or models and they compare it. What is the prediction? So one thing that you can do is to click in the input of rheumatoid arthritis that might help to estimate a higher fracture risk in type 2 diabetes patient. Other way is to increase the age by around by 10 years. Also, what you can do is to decrease the T-score by minus 0.5 at the femur neck. And the fourth modality is by including or adjusting for a TBS value. So no single models was superior to the others, but in general, you can do one of these adjustments to predict or to precisely predict what is their risk of fracture in type 2 diabetes patients. So we've done the adjustment to, with the TBS, as you can appreciate here, her hip fracture increased significantly, and it's 4.3 that's exceeding our threshold for treatment. So basically, this patient at high risk for fracture, and the treatment is indicated. So that's a regard of the case scenario that I would like to highlight. In general, fracture risk in type 2 diabetes. Generally, if you have higher BMD, the fracture risk will be low, but certainly, as Dr. Kamel mentioned, it's not all the case. We have around 50 to 60%, they will fracture in the osteopenia range. So that might explain in part that there are certain conditions that might contribute to that. Type 2 diabetes patients have higher risk for fracture, but also have higher BMD values. So how can that be explained? So when we talk about fracture risk, that's in general, but also it will be nicely demonstrated in type 2 diabetes patient. Those component will be also or the fracture risk will be increased if the bone strength is low. Also, we know that type 2 diabetes patients are more prone for falls. They will have an increased risk of falls. So either because of hypoglycemia, diabetic nephropathy, diabetic retinopathy, also other risk factors also for falls. So that might contribute to fracture risk increment in those patients. When we talk about bone strength, as Dr. Kamel mentioned, we're not talking about BMD alone. As we've seen here, we have higher BMD, but higher risk for fracture. But the bone quality that's impaired in those kind of patients, and the quality of the bone it's impaired, they will have lower bone turnover. They will have also impaired in the microarchitecture of the bone, and also weakening of their material properties. So probably type 2 diabetes patients have higher BMD, but at higher risk for fracture. A recent meta-analysis that has been published last year, they include around 12 studies, most of them cross-sectional studies. As you appreciate in the first plot here, that the TBS value was lower in those with diabetes in general, where they include type 2 and type 1 diabetes, in comparison to non-diabetic individuals, where they include more than around 40,000 patients. So type 2 diabetes have lower TBS values in general in comparison to the non-diabetics. Does it reflect into fracture risk? What is the utility of TBS in regard to fracture risk prediction? So again, Leslie and his colleague from Manitoba study that where they include a large number of cohorts, more than 29,000 patients, 8% of them are having diabetes with a follow-up for around 4 years. As you can appreciate here in the table, with the BMD values, BMD in comparison to the control group, the type 2 diabetes patients have higher BMD values, as we have seen in the meta-analysis, but lower TBS value in comparison to those without diabetes. That was adjusted for multiple risk factors, of course. So in general, type 2 diabetes have higher BMD values, but lower TBS values. So the question, does it reflect into fracture risk prediction? In this study also, TBS predict major osteoporotic fracture that was independent from the BMD alone, especially in women. That was more pronounced in women with type 2 diabetes. So what they conclude from this study, that TBS will capture a large portion of diabetes associated fracture than a BMD alone. So in addition to the BMD, you can add the clinical risk factor, TBS, so your prediction for fracture will be much better. So what is the effect of glycemic control? Those with well-controlled diabetes and poor glycemic control, are they the same in regard of the TBS values? The answer is no, there are differences in that regard. Those with a poor glycemic control, defined in this study as having A1C of 7.5 or below, have a significant lower TBS values in comparison to people with a well-controlled type 2 diabetes, basically A1C of less than 7.5. So again, Dilwale and his colleague summarized their finding that the TBS is lower in type 2 diabetes, TBS associated with a poor glycemic control in general, which might explain in part these increased fracture risk with a higher BMD in people or individual with type 2 diabetes. What about duration of diabetes and its effect on the TBS values? So we've presented this study at the last meeting of SBMR in September this year from our center. Longer duration of type 2 diabetes has been associated with poor bone microarchitecture that was assessed by the TBS, where we recruit around 200 patients, mainly females with a mean age of around 65. We have a good number of the type 2 diabetes patients, of around 50% of our study in these patients, and 64 patients where they have a long-term diabetes. So basically, we defined duration of diabetes. If they have diabetes within 4 years, we classify them as a new diabetes, and longer duration if their diabetes duration exceeding 10 years for the purpose of the statistical analysis, of course. What we have found is that lower BMD, or actually higher BMD values in those with type 2 diabetes, as you can see here in this figure. And also there was a trend toward lower TBS values in comparison to those without diabetes. Of course, the TB or the type 2 diabetes have higher BMI. That might explain, of course, because of the metabolic syndrome, obesity, and other risk factors in type 2 diabetes patients. And we have to keep it in mind, especially with the TBS, because it might cause some noise in that regard. If you have higher BMI, that might affect, but we've adjusted for BMI, and it was significantly higher BMD and also lower TBS values. So again, in this box plot, as you can see here in the left or in the right-hand panel, that those with a newly diagnosed type 2 diabetes in comparison to long-term diabetes, long-term diabetes have lower TBS values. Also with the poor controlled diabetes, there was a microarchitecture deterioration and lower TBS values in comparison to those with well-controlled diabetes. It was the TBS value correlate actually weakly with the BMD, but negatively with the type 2 diabetes duration and also the glycemic control defined by the A1C here. Majority of patients who's having long-term diabetes have a degraded structure. So that's a regard of type 2 diabetes and its relation with the TBS values. There are, of course, other conditions. I will not go through all of them in details, but roughly those with a type 1 diabetes in this study, where they have a control group in comparison to type 1 diabetes, no big difference in regard of TBS values between two groups. But interestingly, that those with a type 1 diabetes, if they have fracture, their TBS is lower in comparison to those without fracture. In regard of glucocorticoid exposure, that has been defined in this study, having prednisolone or its equivalent 7.5 milligram dose for more than 3 months. So we have two groups where we have glucocorticoid patients. In general, TBS was lower in comparison to higher BMD in this group. The TBS was able to distinguish clearly the individuals between those with a fracture and without a fracture in glucocorticoid groups. Other also element that we can use or other disease is the primary hyperbara. And interestingly, in this study, they study around 92 patients with the primary hyperbara in comparison to the control group. Those with the primary hyperparathyroidism have lower TBS value and also associated with the increase in the fracture risk, mainly in the vertebra. What happened after the surgery, those patients proceed, 20 patients proceed with the parathyroidectomy, and after 1 year of the surgery, the TBS increased nicely without any medication, perhaps because of the effect of parathyroid hormone and catabolic effect on the bone. As Dr. Kamel mentioned about oncology patient and the breast cancer patient who is taking aromatase in this RCT, where they recruit around 70 premenopausal women, they subjected this group either to zoledronic acid and placebo. It's clearly that if you have patient on aromatase inhibitor, you will have a dramatic decline in regard of BMD values. That was expected from the previous study, where we have around 4% decline in the BMD values with the aromatase inhibitor alone. The TBS was not much of decline, but if you give patients zoledronic acid, a significant increase in the TBS and also in the BMD values in comparison to the control group. So perhaps having zoledronic acid treatment in this study was 4 milligram Q6 monthly, was significantly increased the lumbar spine, the BMD, and also the T-score or the TBS values. So it will preserve the bone and will contradict the effect of aromatase inhibitor. So that's in general in regard of secondary osteoporosis. I have few slides on monitoring and the role of TBS and monitoring. Of course, like the Dexa scan, if you want to monitor the treatment response or the disease progression on the BMD, you need also the persistence assessment, and you need to calculate what is the least significant change. That will be similar with the TBS and BMD also, based on the reports, clinical reports available. So the TBS precision was quite good, actually. It's lower than in comparison to the BMD, but the TBS precision from this study around 1 to 2.1%, the least significant change that has been proposed by the International Society. If you don't have your own institute, least significant change, roughly between 3 to 5.8%. So we'll move to the effect of oral bisphosphonate. So we know that the antiresorptive have, you can see a significant increase in regard of BMD. As you can see here in the figure, those patients treated with the antiresorptive therapy, namely oral bisphosphonate, and also they include raloxifene and calcitonin in this study. They have a significant increase in regard of BMD and in comparison to the placebo, but the spine TBS was not that much. So we have minimal TBS changes in those treated patients that was not significant. clinically in those kind of population, the oral bisphosphonate. What about the IV bisphosphonate, namely zoledronic acid, from Horizon study, where they recruit those patients for 3 years and they subject those patients to zoledronic acid or placebo, a significant increase after 3 years, around 9.5% of increase in regard and gain in the BMD values, but the TBS was not that high, 1.4% after 3 years of therapy with the zoledronic acid. So as you can see here, a very dramatic increase is seen with the BMD, but not that much in regard of TBS values. So the TB increased only in 35% of those patients. If we talk about the least significant change in this study, that was 3.1%. Denosumab, as you can see here, after 3 years or 36 months of denosumab therapy in comparison to the placebo, significant increase in regard of BMD, also significant increase in regard of TBS values, around 2.4%. Whether this has a clinical significance or not, no, so it has been defined in this study, the least significant change around 5%. So there is an increase in regard of TBS, but that's not exceeding the threshold of precision or least significant change. So in comparison to the other studies, TBS gain was superior in regard with the denosumab in regard or in comparison to both oral and also the IV bisphosphonate. TBS increase more than 5.8, which is least significant change in the study, only in 20% of those patients. Also, we've done this study in 2017 with Dr. Kendler in Vancouver, where we presented the study at the SPMR 2017. We recruit around 200 patients, 106 patients treatment naive, and around 99% of patients switch from zoledronic acid to denosumab. And we've observed the changes in regard of BMD and also the TBS value. Does it have an effect in that regard? So the BMD was with the treatment naive, as expected, nice improvement, around 4 to 6%. It's like the clinical trials or the FREEDOM study that we've seen. So here around 5%. Those who switch from zoledronic acid might have a blunting effect, and 3.8% change in regard of BMD. The TBS value was not that significant, actually, around 1.6 in the treatment naive, and almost similar in those who switch from zoledronic acid. So perhaps no big changes in regard of anti-resorptive therapy with the TBS values. What about the anabolic therapy? So with the teriparatide, in comparison, not to the placebo, but also the oral bisphosphonate, there was a significant increase, perhaps because of the changing in the microarchitecture of the bone, where we can see a significant increase in regard of the TBS value, 4.3%, that exceeding the threshold of this least significant change in this study. So that was significant with the teriparatide in comparison to oral bisphosphonate, namely ibinronate in this study. Abaloparatide, which has been already approved in the US, and so with the abaloparatide, a dramatic increase or significant increase that exceeding 4.2% in comparison to teriparatide in the study, around 2.2%. So the placebo was negatively decreased, but significant increase after 2 years of course of either abaloparatide or teriparatide. So it was significantly increased. In general, what is the effect of therapies on BMD and TBS? To summarize, what is the effect in regard of TBS? As you can see here, a significant and nicely improved TBS after 2 years of therapy with the anabolic therapy, namely teriparatide and abaloparatide. We don't have study as far as I know in regard of romosozumab yet. In regard of denosumab, a significant increase, but it's not exceeding the threshold of least significant change. Nothing much in regard of bisphosphonate. Hormonal therapy almost the same. With the glucocorticoid, we have significant decline, and similar to that or more is the aromatase inhibitor. This is coming two slides. I found it, or that was a talk and personal view of Dr. or Professor Michael Lewiskin in one of his presentation. I like this slide. I want to share it with you. So in regard of monitoring based on its personal experience and best available data that we have, if you have a TBS that's decreasing and the patient is not on treatment, that perhaps constant with an increase in regard of fracture risk and fracture risk prediction. If the patient on treatment and things are declining in regard of TBS, that might suggest suboptimal response to therapy perhaps, and you might consider further evaluation and in regard of compliance or emerging secondary causes. But if you have a nice improvement or an increase in the TBS and the patient not on treatment, that's unlikely to occur. Unlikely to occur. But if the patient treated, that's of course associated with the favorable response to the anabolic. Does it reflect into a clinical significance? We don't have this data yet. Perhaps some improvement with the denosumab, but we are not expecting much with the bisphosphonate in regard of TBS changes. As Dr. Kamel mentioned about including the TBS in the official guidelines in regard of type 2 diabetes management with the IOF, they include also the Dexa. If you have a FRAX that has been adjusted with the TBS values, so it has been included in the guidelines in regard of further management of type 2 diabetes and osteoporosis. The official guidelines that has been published in last December by the International Society of Clinical Densitometry. Just I would like to highlight this in regard of monitoring of therapy. If you have the role of TBS in monitoring of therapy with antiresorptive, well, it's not clear. As we have seen also in these studies, the TBS has a potential role in monitoring of therapy with the anabolic therapy, of course. And they clearly mentioned that TBS has been associated with the major osteoporotic fracture, so the ability of fracture prediction with the TBS in both menopausal women with type 2 diabetes is there. So it has been recommended as one of these official position in this guidelines. So to summarize, trabecular bone microarchitecture induced with a type 2 diabetes using TBS are compromised. That might explain in part the increased fracture risk despite preserved or higher BMD values in comparison to the control group. TBS has the ability to predict the osteoporotic fracture in those with type 2 diabetes. Also, the greater architecture deterioration that we've seen in the individuals, mainly in the long-term duration of diabetes, above 10 years, and also those with a poor glycemic control of A1C of 7.5 and these studies. In regard of monitoring of therapy, we should do the precision assessment, and there may be a role in regard of monitoring therapy, especially in those who's taking anabolic therapy. With that, I would like to conclude. Thank you for your attention, and mic is yours, Antoine. Thank you.
Thank you very much also to you, both of you, your presentation which was very clear. We have some questions. I mean that we had some people who had a question on the technical aspect of TBS, and I think some of them I can answer myself because they're related to the algorithm and how TBS is calculated. We also have some clinical question that I will be asking both of you. Feel free to both of you comment on them. I think Dr. Kamel, if you were back with us.
Yeah,
I will.
I'm
Perfect.
here.
Thank you. Excellent. We will see you in a second. So I will start to answering this question, which was about the brightness of TBS and how it's related to the brightness of the pixels. I mean, so when TBS is calculated, the brightness of the TBS of the cells, the pixels that you see is not really taken into account. What matters is the variation of the brightness between one region and the other, and that's how it was correlated with the trabecular bone score that Dr. Kamel was mentioning, the spacing, the numbers, etc. So the algorithm was developed in a sense that this variation of brightness reflects whether there is this trabecular quality.
I understood it in this way, actually, Antoine, that if you have variation in brightness, meaning that you have bone and space adjacent to each other. If you don't have variations, then you have a standard, whether it's bone totally or large amount of bone or large amount of space.
True.
This will tell you that you don't have a good bone.
Correct.
If you have no differences in the brightness. So the more you have brightness, the more you have better quality of bone, more trabecularly. Okay.
That's exactly right. Yes, indeed, doctor. We have a question regarding the Dexa machine brands and the difference that might happen between one brand and the other, or even I will even state between the different models between the same brand. So when TBS is installed on the Dexa machine, there is a calibration performed with a special calibration phantom, and this calibration brings all the machine for standardization that was done, and be able to compare, evaluate the patient on the same level. There is still recommendations to when patients are not from the same machine, but as it is some with BMD, it is important to look at trends rather than the values themselves, but still this calibration was done in order to bring all the same values together and reflect the cutoff values that were defined by IUF and ISCD, so 1.31 and 1.23. I will end with a recommendation on because there is a question regarding metal implants or prosthesis. The artifacts applying to TBS are almost all the same as for BMD. So if there's some exclusion because of metal plates, anything that applies for BMD, they will also for TBS. Dr. Kamel mentioned truly that there are two facts is probably osteoarthritis and degenerative change that have shown some studies that have less impact or very small impact on TBS. So some spine with arthritis might be considered to apply TBS, where they should be excluded for BMD. Both of you doctors, if you there is a question about mixed diagnosis and what is the mixed diagnosis of BMD with this absence of TBS? What is your experience in your practice?
Actually, let me answer. In Lebanon, in my country, we have too many types of Dexa machines. We have the GE Lunar, we have the Hologic, we have different other types. Probably they are cheaper machines. Actually, we don't know the correlation between the different results. I personally advise my patients to do their DEXA scans every 1 or 2 years on the same machine, not to change centers, because they should have the same technician, same standards at that center, okay? And we all know that TBS is only found or implicated in the GE Lunar and the Hologic machines. If I think clinically, in my clinical practice, I need to have an idea about the bone quality, I send my patient to a center who have the TBS there. Otherwise, I have to accept what's there actually, because we have very few centers in Lebanon that have the TBS their machines. Okay, this is what I do. I don't know on the KSA what they do.
Yeah, so basically, even before we're having TBS, just I would like to say that the BMD or the DEXA scan is still the gold standard for diagnosis.
Yeah, for sure.
TBS is not recommended for a diagnosis yet. Still, the DEXA scan is the golden star or the golden and standard tool for diagnosis of osteoporosis. Keep in mind there are certain limitations. A clinician has to know that there are certain conditions that might affect your DEXA scan values and also the interpretation. So FRAX was initiated and was there, so that will help you in that regard. So having DEXA scan in addition to the FRAX tool, that will help to predict their risk for fracture. Of course, if you don't have the TBS, that will have an added value in the clinical scenarios, of course.
Okay.
Sam, thank you for sharing. We have 2, even 3 questions around the use of treatment, and do you agree, or what would you comment on initiating either bisphosphonate or teriparatide as being an option to starting treatment, and in teriparatide, shall we increase duration of teriparatide to more than 18 months? So there's this question on which to start with, and also how long. Dr. Mohammed, do you want to start with this one?
Yeah.
So in regard of which one to choose, and does the TBS values will help you in regard of which one to choose, either anabolic or anti-resorptive therapy. It has been suggested that if you have very low TBS, you might consider anabolic therapies. So based on the available evidence, what we have now. But basically, of course, because of anabolic therapy, we have other limitations, that's subcut injection on a daily basis on most of these anabolic therapies. And also because of the cost, probably first choice always was the bisphosphonate because of cheaper availability and also the efficacy. But in general, now the trend now towards starting with the anabolic therapy, then switching to anti-resorptive therapy after that. In general, the limitation of anabolic therapy is based on the studies that we have, and we have a black box warning with the teriparatide and also the abaloparatide of increased risk of osteosarcoma. For that, the limitation, it has to be for a total of 24 months in total, from 18 to 24 months, based on the best available evidence that we have so far.
Mm-hmm. Dr. Kamal, do you want to complete, or you agree?
I agree.
Okay.
But I have a question to Dr. Muhammad, actually, because apparently he's more experienced than me in treating secondary osteoporosis. Just I have a clinical question. Actually, I've not read the latest updates on the TBS recommendations with the ICD or something like that. If a patient has uncontrolled diabetes and he has a normal or acceptable BMD, but he has a very low TBS, practically, do you jump and treat this patient with, let's say, a teriparatide or not?
Yeah, so that's a tough question in regard of you will depend on the TBS values to treat. Whether based on the official position from the International Society of Clinical Densitometry ICD, that will not treat based on the TBS. All the guidelines not yet approved the use of TBS for initiation of treatment based on the TBS values alone. But if you have the TBS values, in addition to the clinical risk factors, of course, and using the FRAX criteria and doing the adjustment with the FRAX with the secondary osteoporosis values, with the BMD, of course, you will have a better estimation in regard to fracture risk. But if you have alone, in the studies, if you have very low TBS values, even if the BMD is okay, it has been associated with increased risk of fracture, independent of the BMD value. But will you initiate the therapy based on that? That's the question. Mm-hmm. So based on the available evidence, that just your threshold for treatment will be lower, but use the FRAX, use the BMD in combination with the
regular way, I mean.
Exactly.
Okay, thank you.
Connecting also, making the connection with a FRAX question that we had, Dr. Mohammed, you operating in Saudi Arabia, and there was a question on the FRAX curve that you use. Do you use one from USA, or is that the one from Saudi Arabia?
So hopefully we'll have our own soon, inshallah. So we're a group of Dr. Yusuf Al-Saleh and his colleague working on creating a fracture in collaboration with the IOF group. Hopefully we'll have this result soon. So we'll be able to use our own fracs currently based on the guidelines from Saudi Osteoporosis Society that has been published in 2014, that the recommendation is to use the US more robust data. Other options to use the Lebanon or Kuwait or Abu Dhabi. So there are differences in that regard, but the guidelines from Saudi Osteoporosis Society in 2014 is to use the US Caucasian data.
Okay, excellent. Good to know, and that fully that you will have also your own curve soon.
Sure.
I think Dr. Kamel will have a question on rheumatoid arthritis. And so if there is a patient with rheumatoid arthritis and want to do fracs adjusted with TBS, do I need to click on the array fracs variable? If yes, is it going to double count the rheumatoid arthritis risk in fracs and in TBS? As a rheumatoid arthritis patient have lower TBS comparing to non-RA patients?
If you click on the rheumatoid arthritis, this will be counted in the fracs, but not all rheumatoid arthritis patients have probably low TBS. It depends on the other risk factors. The patient has taken a lot of steroids, or the patient has very old rheumatoid. It depends. So this is the way to do it. To start with, it will be implemented in the risk factors of the fracs, and then depending on the other factors, it may or may not be part of the bone quality of the patient, or then the TBS.
Okay. Excellent. I think we have answered almost all questions. We will be able to receive all the questions. Please feel free to contact Medimaps if you have attended this session, and if you have further questions, I will be happy to guide you to Dr. Mohammed and Dr. Kamel. Thank you so much, doctors, for participating to tonight's webinar, sharing your experience, also how you manage it with your own patients. It was very useful. And if you have no other maybe comments for tonight, we can stop it now.
Sure.
Thank you, Antoine. Thank you,
Thank
Mohammed.
you so much.
Thanks
for the
Dr.
attendance. We hope
Nice
you
to
like
meet
it
you.
and
Nice
you
to
have
meet
a good rest of the night.
Sure.
Thank you.
Have a good
Inshallah, we'll
night.
meet in Lebanon one time. Okay.
Sure.
Nice to meet you,
Hopefully,
Mohammed.
inshallah.
You too.
Assalamu
Thanks.
alaikum.
Salam.
Bye.
Bye-bye. Bye-bye. Bye-bye.